Welcome to Healing with Her, the podcast where women in medicine share bold and honest conversations from the front lines of healthcare. Step into the world of Black women medical professionals as they unpack the power of healing, the weight of care, and the beauty of showing up whole.
Welcome to Healing with Her, the podcast where women in medicine share bold, honest, and healing conversations from the front lines of healthcare. I'm your host, Dr. Jolie Sosa, and I'm thrilled you're here. Whether you're a healthcare professional, someone passionate about wellness, or someone who is looking to gain more knowledge about your own health and well-being, you'll find stories here that resonate, educate, and inspire. This podcast was born from a shared truth. Healing isn't just about medicine, it's about connection, listening, and leadership. And who better to lead those conversations than women physicians? Disclaimer, the information that we share today on Healing with Her is intended for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified healthcare provider with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of their institutions or employers. Hello, everyone.
Hello.
Good to see everybody
Good
again.
seeing
It's been a
you.
little while since I've been on. Yeah, so it's good to see everyone.
Hello.
Today we have a fun guest. I'm so excited that she's here because this is the kind of person I think most folks in the community may not necessarily encounter in an office, in a clinic. You may barely remember you met her because of the medicine she gave you. And we're so excited to have Dr. Karen Francois, anesthesiologist, with us today.
Hello, everyone.
Thank you for
So
coming.
happy to be
Thanks for
here.
coming.
This is an honor, and I'm very grateful that you invited me.
Yeah. So I'm fortunate to get to work with Dr. Francois at Children's Hospital, and she's often the person making sure my patients are well taken care of, that they are breathing, their heart rate's fine, their blood pressures are stable while we do surgery. And as we were talking, we realized, this is something that most people don't really get to ask about. So we decided to have you on to sort of shed the light on the world of anesthesia, right? Because I think many folks just think, oh, they just put me to sleep and that's it. Or sometimes just like, what do they do? But before we get into it, I want folks to learn a little bit more about you. Tell us about how does one become an anesthesiologist, how many years of training you go through, and then what exactly an anesthesiologist does.
Okay. So an anesthesiologist is, again, yes, that person that's kind of secretly making sure that you're good during surgery. We're not really well known outside of that, but it is a role of a physician. So I am a doctor. I did go through 4 years of undergraduate training. Then after that, I did medical school for 4 more years. And then there's an additional 4 years of residency at the base. So there's an option to continue on to become a fellow in a special subspecialty of anesthesia if you do an additional 1 to 2 years after that. So that's a minimum 12 years after high school. So I've been a general anesthesiologist for over 10 years now. I love my job. This is the job that I never knew about that was perfect for me.
Yeah.
So most people don't even in medical school know that this is an option, that you can go to school, become a physician, and take care of patients that are having surgery by keeping them safe and comfortable. So I'm very, very happy to be where I am, and I'm happy to educate and just let everybody know what we do and what's going on when you're sleeping.
Yeah. Thank you. So what exactly is anesthesia? It's pain relief, like you said, you keep patients comfortable. Obviously, all surgeries, you can't be awake for them. So, the patient is asleep, sort of. What happens during surgery for a patient?
Yeah, so there are many different levels of anesthesia depending on what type of procedure you're having. So specifically, a lot of people will have sedation for like a colonoscopy, and then they're assuming that that's anesthesia. But there's so many other ways to get through a procedure and be comfortable and not aware. So you can have sedation, like I mentioned, for colonoscopy. It's usually through the IV you get. and it makes you unconscious. You're not able to feel what's going on. You're not able to see or remember anything or hear what's happening usually. So we call that a deep sedation. But then if you're having more significant surgery, then you're going to be going under general anesthesia, which involves a lot more medication, usually something to help you breathe while you're under anesthesia, because most surgeries you're not supposed to be moving. We have to make sure that you're still, and that includes stopping you from breathing. So you'll get intubated, and those medications will be breathed in. So you can have general anesthesia, which you breathe in, and also you can have sedation, which is mostly IV.
Yeah. I think a lot of folks, when they probably have that picture of a mask being put on their face, and people count backwards, and then they're off to sleep. Is it like that?
In some ways it is, but nowadays we don't really use the mask to put you to sleep. That was probably back in the day when they had like the chloroform cloth. Just knock someone out with one breath. But now we use most of the medications through the IV, which is much safer, much better tolerated, less likely to cause side effects. So we do give a mask. The mask doesn't have anesthesia usually. It usually just has oxygen. And that's just to help you, again, prepare for that point in time when you're not breathing. So you're getting a mask, but we're sneaking in the drugs through the IV.
IV, exactly.
At the same time.
Yeah. And what are you actually watching and managing while that patient is asleep, is under anesthesia during surgery?
So everything. So our motto is vigilance. So we always have to be vigilant, constantly checking your blood pressure, your oxygen levels, your heart rate and rhythm, definitely how much anesthesia you're receiving and how much we've given. We're watching all those things. But most importantly, we're making sure that we see your vital signs as a whole. And that tells us, okay, is this person really deeply asleep, or do they need more? Or is this too much? So we just look at all these numbers and it tells us a story. It's basically your communication with your anesthesiologist, all your vital signs.
Yeah. And that's, us surgeons, we all operate. It's really important during the case, the anesthesiologist is behind or draping, but oftentimes we'll say, is she okay? Can I have more Trendelenburg? Which is not really your job. Your real job is, but so heart rate doing okay. If we have a bit more blood loss, we have to let you know, because you're the person who then, if there is a emergency or concern, you're the one sort of leading that too, getting things prepared and ready to make sure that person stays safe and is okay.
Exactly. And that's what a lot of people don't know. They think it's kind of like a switch, or, you give the medications and it's a set it and forget it. But honestly, it's a dynamic situation. You're constantly in communication with the surgeon, nurses in the OR, everyone. Yeah. And if you have a concern, you voice that concern. If you think the patient
is moving too much,
is suddenly in need of more medication.
Can she be relaxed a little more here?
And that communication is important. So, and then, in the situation when there is an emergency or something critical happening, we all need to speak up. And from our standpoint, we're the patient's advocate.
Exactly.
So I need to make sure that while you're asleep, the surgeon understands that you probably are not tolerating this, or we need to stop this, or we need to reconsider the approach.
Yeah.
So
I would I agree too. If you had something to add, Teresa.
I was wondering, I get a lot of patients on OB who are getting a spinal versus an epidural. And a lot of them are very fearful. I don't want that needle in my spine. And I'm like, well, it's not really going into your spine. Could you tell our audience the difference between the two?
Absolutely.
And
my main focus in my career right now is OB anesthesia. I ended up here. Actually was very, very interested in this as a resident, but I never did a fellowship. But I'm primarily doing OB anesthesia. So this is my life right now. Just explaining what the difference is and reassuring people that it's safe. This is something that's been being done all the time. And your experience, of course, is an anxiety-filled one. You're nervous, you're having contractions, you're in pain. So I think the main job we have is to kind of just verbally reassure patients. So on an epidural, you don't want to see the needle. I just saw someone post, Happy Mother's Day. This is what your mom had for her epidural. And they put the needle up. And I'm like, why are you giving away the secrets? But yeah, there is a needle involved. It's long because we need to have enough to figure out where exactly your epidural space is. And it's basically, we go between the bones in your back. So if you ever feel the back of your neck and you feel those bumps, those are your spinous processes. We go between those bones and we go in with the needle. And we find the space that is right before your spinal column. So it's not in your spine. It's not hitting your actual like main spinal column, which your nerves come out of. We're going to the space before that. And what we do is we leave a teeny tiny catheter in. So the needle has to be big so that a catheter can go through it. It's like a small tube. And then after that, we give medication through that the entire labor. So it's hooked up to a pump. The medication goes automatically, and however long you labor, 12 hours, 24 hours,
41 hours,
48 hours. We leave that catheter in and you get medication that entire time. So that's why we need a large needle. Some people are very worried about like, oh, am I gonna get paralyzed? No, there's a risk of injury with any needle going into your body, but the space that we go into is not close to any major important nerve. There are nerves nearby. So we always have people awake, alert, able to communicate. You know, if you feel discomfort, feel empowered to speak up. Say, I'm feeling this here, I'm feeling that there. That's important information so that, you know, your anesthesiologist or anesthetist can know to avoid anything that's important.
Like if you have, say, scoliosis, or you perhaps had
Herniated
surgery in your
discs
back.
or-
Yeah, exactly.
Yes.
Those things are important. And on that topic, I was going to ask, what are some things you think folks don't necessarily think about, but they should make the anesthesiologist aware of before surgery or any procedure for pain management?
So in thinking about the epidural and maybe having like a difference in your spine, like if you had a spine surgery, if you ever been to a chiropractor and they've like cracked your back, we need to know because things wouldn't be exactly where we expect them to be. It's we're looking at your body, thinking of like an anatomy picture, and if your body's a little different, you need to tell us. But outside of epidurals and spinals, we need to know for any surgery procedure, most importantly, your medical history. So a lot of people are unaware of some of their medical history, it is what it is. I would recommend, if you don't know exactly what your history is, just bring a list of your medications, and we usually make some deductions from that. We can figure out, okay, you're on this is probably for blood pressure elevation, you're on this, you're probably diabetic or what have you. Always be honest. You know, if you are someone who doesn't know what's going on with your body, but you have certain symptoms, like you have fainting spells, you get dizzy with exercise, you get short of breath, you can't walk a full block, you smoke cigarettes, let us know. We just need to know. We're not here to judge. If you do any other substances, just be very, very honest, particularly marijuana. It seems like, you know, it's not important, but it is important to mention that because all of these things affect how your body responds to the anesthesia, pretty much. So you may have some issues that we could easily prevent or fix if we know. So just be honest, and then ask questions. If you don't understand what's going to happen to you, be empowered to ask. You know, what meds are you giving me? What's going to happen afterwards? What are the side effects?
Yeah.
Just be very, very empowered to open up, speak up, advocate for yourself, and your physician or sometimes there's a nurse anesthetist there. They're able to answer these questions, and they should. Yeah.
What about like family history?
That's a good one too. For anesthesia, family history is important, especially if you had a family member who's ever had a very strong reaction to anesthesia. There's one particular reaction that is severe and can be life-threatening that we need to know about. So they'll often ask in surgery pre-op, have you ever had any problems with anesthesia? Any first-degree family members with anesthesia issues? And we're looking for a specific reaction that can happen when someone gets general anesthesia that causes them to basically go into this critical state.
Mhm.
Very, very important to know. Um, should I mention it?
Yeah.
Yeah.
It's called malignant hyperthermia.
Uh-huh.
It's very rare, but it is passed down, usually first degree relatives. So father, mother, those kind of relations. An aunt or uncle may not have such of a bearing, but if it's like a father, mother, sibling that had a bad reaction, we need to know. We need to know.
And if they do find out that that family member has, would that prevent them from having surgery, or like, what would be the precautions then?
So you can still have your surgery as long as you're mentioning this. There are precautions we take. We don't give you any anesthesia that you breathe in. All the anesthesia will be through the IV. We have to prepare the anesthesia machine, so it doesn't take extra time to get you ready for surgery, but it doesn't mean that you cannot have your procedure.
Oh, good to know.
Okay.
That's good to know.
And then you have some people who are just afraid of surgery. You watch too many bad movies. Like they wake
I
up.
love Grey's
Okay.
Anatomy.
Oh, Grey's Anatomy.
Right? Too many medical shows. I woke up.
Yeah, I woke up during surgery.
Or they have
yeah.
that fear. So,
Yeah.
I mean, have you ever experienced that with a patient who's just like kind of freaking out? Like, what if I wake up?
Oh yeah, yeah. I've actually had one patient who, and she was such a lovely woman. She was just telling me like, I heard everything, and this wasn't in a procedure that I had with her. This was in a former procedure, a prior procedure, and she was talking about like what she heard, and I was like, there's no way you would know this unless you
actually
were
heard it.
aware.
Mm-hmm.
Because she was describing things that our surgeon usually says, and like very specific things that would only be, I mean, I don't think even Grey's Anatomy would cover this, but it's just like different things that we do in our OR. And I was just like, yeah. So that could happen. It is extremely rare. I want to say in the order of like 1 in 100,000 people will ever experience awareness under anesthesia in standard setting. So the risk factors for awareness are if you're having an emergency procedure, like a stat C-section, where you need general anesthesia, or your
Appendix or something.
Maybe not even an appendix, because we would give full-on general anesthetic for that.
Okay.
I'm talking about people who've been in like a car accident. You had a trauma, you're bleeding. We don't know if you're going to be stable. So then we would probably give less anesthesia, and then you have a higher risk for awareness. But in those settings, we're more concerned about getting you through the procedure alive.
Mm-hmm.
So it is, there are certain situations where you would be at a risk for awareness. But in your standard procedure, you're coming in for your gallbladder to be removed, or you're having a hysterectomy, you're not going to have abbreviated anesthetic. You're going to have the medication that you need. We're going to be checking your vital signs, and we're going to make sure that you're asleep. And it's very, very, very safe now. I want to reassure people. I've only heard of that one case my entire 10 years of doing this. So.
And what about nausea? After a case where they wake up and they're just, you almost have to keep them because they're hydrating. Are there things that you can do to help them out?
Yeah. Nausea is common, especially with GYN surgery. There's a couple of types of surgery that are more likely to cause nausea. So GYN, breast surgery. Why do women have to suffer?
Good point.
If you're a woman, that's a risk factor. If you're a non-smoker, like for all the times that you could have had like a negative effect for not smoking. If you have motion sickness, eye surgery, that's another one that causes like a higher risk for nausea. So prevention, just mention, if you ever have had car motion sickness, boat sickness, if you've been nauseous with another exposure to anesthesia, speak up, let your doc know, let your anesthetist know. And there are things we can do. We can give prophylactic medication. There's a patch we can put behind your ear. It's kind of like the motion sickness patch. And we put that on before surgery. And the thing that usually causes nausea are the gases. So it triggers something in your brain that makes you extremely reactive afterward. And a lot of the opioid-related medications can cause nausea. So if you tell me that, I've had nausea before, I was throwing up, I couldn't leave on time, I will adjust my entire plan. So you're not getting any gas, and you're going to get the patch behind your ear. You're going to get some IV medicines that we give before and after surgery, so that you have a good fighting chance to make it through the procedure without having that reaction.
Okay, so they just need to be able to tell you that.
Yes. And we often ask if we see that you check some of those boxes, gender, non-smoking status, motion sickness. Yeah. Having those kind of procedures. Yeah.
Good stuff. You sort of touched on this before, but what are some, as an anesthesiologist, if you're looking through a patient's history, that sort of checklist you do before, what scenarios are you concerned about, and sort of to make our audience aware of things that may put them at higher risk for negative outcomes in a procedure? One I could think of, you had mentioned smoking could potentially do that. What other things are you looking for when you're assessing a patient, and whether, when anesthesia says, actually, we're canceling this case or we're not moving forward, what are those things?
Hard stop.
Yeah, that you think, okay, it's not safe enough to proceed with this patient, or I have to be on higher alert.
So if I see in the history, or I get this from a conversation in the pre-op area, a patient has recently used a substance, that's a cancellation. There's no way we can fix that. So let's say you're extremely nervous before surgery and you're just like, I'm not going to make it into the hospital unless I take this or that. That would be a risky thing, because the medication that you're going to receive under anesthesia actually works very similarly to a lot of substances, like specifically marijuana. It works in the same centers of the brain. It actually, if you come in and you've just recently ingested or smoked, it will change how much anesthesia your body can tolerate. So we actually would give you what we think is standard, and it would be maybe too much for you. And you may not wake up quickly. You may have issues with breathing if you're a smoker. That's something that we often see. So if you get general anesthesia, we're putting a breathing tube in. We're assisting your breathing with the ventilator. If your lungs are already irritated, inflamed from smoking, that can cause a negative reaction when it's time for us to try to ventilate you, and also when we're trying to remove the tube. We see a lot of reactivity, a lot of low oxygen levels, and the lungs reacting in a way that doesn't allow it to deliver oxygen to you properly. So we need to know. It's important. It's for your safety. It's actually very risky. It could lead to very complicated problems after surgery. Outside of substances, if you're having any chronic illnesses, we need to know about it. If your blood pressure is way out of control, we really cannot safely do surgery on you that day. If you're having like a diabetic, let's say like a high blood glucose, your sugar is really high today, or it's really, really low today, it's not safe to do anesthesia, because you can cause those changes in your blood glucose can change how you metabolize drugs. Also, we would want to make sure that we are able to have a good assessment of how your mind is working, your brain is functioning, and if your blood sugar is low, we won't be able to really know like whether or not you're having a bad reaction to anesthesia or if it's just blood sugar. So we need to be aware of those things, and sometimes if it's way out of whack, we just cannot safely do the procedure.
I had a patient once so I'm a podiatrist. So I had a patient once, and you go through the whole thing. What are we doing today? Blah, blah, blah. When is the last time you had something to eat or drink?
It's the big one.
And this person was like, oh, I didn't have much. I had a protein shake. I was like, so great. So please explain to our lovely audience the importance of not eating or drinking when they tell you not to eat or drink before you have a procedure done. Please.
Yeah. We're not just trying to torture you.
Right?
We know you're hungry.
They'll be like, my surgery's not till 2.
We just need you to hang in there for this one day.
Yeah.
It is so important. It's actually life. It could be life or death.
Yeah.
to make it very plain, if you have a full stomach and you're going under anesthesia, basically what anesthesia does is relaxes your entire body, as you would appreciate. You don't want to be stressed, but your entire body's relaxed, and that makes it a little bit challenging to swallow, a little bit more challenging to prevent anything that might be in your stomach from backing up. So if your stomach is full and you're undergoing anesthesia, we're placing the breathing tube, we're in your throat area. At that point, something could back up, especially if your stomach is packed with things. That food, that liquid, can actually go into your lungs. So like when you swallow the wrong way, you feel like you have to cough for the next hour.
The wrong
right.
type.
You're just coughing. That's your body saying, we don't want liquids in here. We don't want food in our lungs. So you're not able to do any of that under anesthesia. You're completely relaxed. It's just going to go down into your lung. It can cause a pneumonia. The pneumonia can be fatal. So that is the reason why we say, do not eat or drink 8 hours, not 6. 8 hours. This is my hill that I will die on. I don't negotiate, and for nothing by mouth, it's 8 hours. There have been some changes to the guidelines where you can drink a carbohydrate drink, but listen to your surgeon. Go with the instructions they give you in the office. But to be safe and not have your procedure canceled, don't eat anything for after midnight. Just don't.
Every hospital probably has.
Exactly. And he
There'll
could not understand why we had to cancel his case.
I think it's really, I think, again, because people don't see you, the anesthesiologists don't remember you, many times I think it's our job as surgeons to just sort of explain why it's necessary, which is a lot. There's a lot to explain when you're doing a pre-op visit and you're already talking about the procedures, a lot for a patient to digest. But so much of the information and instructions we give is for safety, not just purely for inconvenience. Everything has a purpose. And even with, wearing jewelry and piercings during surgery, we avoid those for a reason. And so thank you for sharing that and letting patients know that it's really to make sure that they're able to wake up after surgery, not with a tube still in their down their pharynx, larynx, pharynx. And that they they go home safely without you're not coughing daily afterwards as a result. You're not having any sort of chest burning or throat burning because some of that extra fluid came up or whatnot. Those are the things that matter.
I think 2 things that I've noticed are the permanent jewelry that they don't tell you about because here in Buffalo everything's covered up until they show up. So I want to get your take on that as well as your take on the GLPs.
Oh, yeah, that's a good one. So permanent jewelry, it's kind of, it's becoming a lot more common. I think it depends on the procedure. Would you say, Dr. Sosa? Sometimes we're not using the electrocautery, which is like a electric knife that can heat up any metal that's on or in the body and can cause burns. So that's the concern that is there with the jewelry. But it does depend on your procedure, and it depends on, I guess, where it's located.
A lot of ours is below the belt.
Yes, below the belt. If you have I often see a nose ring that cannot come out. I've had this forever. I don't even know how to take it out. So that can also get in the way if we're trying to manage your breathing, your airway. Sometimes we do need to place things in your nose.
Yeah, we've gone in with the jewelry cutters at times. Because again, I think I had a patient once, it was in the lip, and you really need that. You need your mouth clear. You don't need anything obstructing, because if there is an emergency, we can't spend time trying to get that out of the way. Or what if something snags it and then it rips? Yes. So that patient lost the jewelry. She didn't mind, but we had to cut it with one of those jewelry cutters to get it out.
Or it can even go down into your lung.
That's true, yeah. Like,
that
we
is
don't
the
know,
concern that we
yeah.
have, you know, like
Yeah.
a tongue ring, like at the end, it's not there. Where is it?
Where did it go?
Where'd it
We
go?
have no idea where it went. Yeah,
Now
you're
we
right.
have to do another procedure to find it.
Good point.
So,
Good
go
point.
hunting.
Yeah. And then the GLP-1s, yeah.
Yes. So that is important to talk about, I think, because everyone's on them, right? So how do they work? So they're great at weight loss. You know, that's one of the great benefits. But it does so by making your stomach empty slower. So that goes right on back to, you know, coming in for surgery with an empty stomach. So if you're on a GLP-1, let's say you take it once a day, you took it yesterday, you come in today for surgery, you didn't eat anything, your stomach could still have food.
Yeah.
And that's the risk that we're undertaking if we're going to do surgery and you've been taking your GLP-1. So I think right now the recommendations are, yes, if you're taking it daily, you need to go a full 24 hours without it. If you're doing a weekly injection, you need to do at least 7 days, in some cases 14 days, just so that we can ensure that it's out of your system and your stomach is emptying as we would predict it to.
Yeah, and I've, for whatever reason, sometimes patients keep it a secret, and it's really important that, again, like you said, don't keep anything a secret. We're not here to judge, but it is important that we know if you do take it so that we can, one, advise you appropriately. So, you know, if you're on this, you should stop your injection a week before. If you're on an oral, stop it. The orals are 24 hours. I don't even know. The orals, yeah, exactly. Whatever the recommendation is, that we need to know that you stop it in a timely fashion so that it's safe to proceed with your surgery. Yeah. Okay. Well, this is so much good information that we've had. Thanks
Very
so much
good.
for joining us, Dr. Francois.
Thank you for having me.
Yeah, we know that you've have done a stint or two on social media in the past. Where can folks find you online?
Yes, so this is a very amateur hour, but during the pandemic, I felt compelled to make videos to kind of one educate, because we weren't getting any like residents or med students where I was previously working in the hospital at the time, and so I felt like, how are people going to know about anesthesia?
Yeah.
How are they going to know how to, you know, what to apply for? And so my YouTube channel that I created then is called 3 Anesthesia and Me, because I have 3 daughters. So it starts off a little bit about like how I'm balancing life with being a mom and also working in the hospital, very challenging academic setting at that time. But there's a lot of different videos on there, mostly about like how to get into medical school. What do you need to become an anesthesiologist as far as training and education? So I think it's helpful. And then just some common questions people have. Yeah.
Good stuff. Yeah. So if you're thinking about this as an option for your career, check out Dr. Francois' YouTube page, 3 Anesthesia and Me.
Yes.
All right. Well, we've come to the end of our episode, and we are so glad that you joined us. With me today, we have Dr. Teresa Rush, we have Dr. Brianne Wilson, our guest, Dr. Karen Francois, and I'm Dr. Julie Sosa. Thank you so much for joining with us. The information shared today on Healing with Her is intended for educational and information purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified healthcare provider with any questions you may have regarding your health. The views expressed by the hosts and guests are not their own and do not necessarily reflect those of their institutions or employers. Take care until the next time. Bye.